For those of you that I don't know, my name is Catherine McGloin. I'm an anaesthetic consultant from the Royal London Hospital, and I'm very happy to introduce this first panel, which focuses on the work being done to help and support people affected by violent crime. Oh, that's very close. Okay. So the idea for the panel actually came from Maria Vialli. She'd seen this particular documentary, which was about people who cared for patients that had been affected by violent crime. Not only just to provide the life-saving treatment in the acute episode, but to keep looking after them thereafter and to change their life's trajectories. And to paraphrase Maria, if I may, she said that she was struck by the fact that these practitioners saw the individuals behind the injury. And when I was preparing the introduction for this, I couldn't give this panel a better context than that. Many talks pertaining to violent crime, violent injury will start with incidence, or prevalence, or trajectory of numbers. But as it says on the St Giles website, behind every statistic about young people that are affected by violent crime or injury, there is a person with promise and potential. And the premise of this panel is to speak to the people who work because they believe in that promise and that potential. So if I could introduce them. Firstly, I'll introduce Katie Drillsman-Milgram, who is a major trauma coordinator at the Royal London. My background, Katie is a critical care nurse. She's got extensive experience in looking after the critically ill. She's brought that experience now to bear in the After Trauma team, which is a charity that we're going to hear more about. But as a synopsis, they bridge that gap between the medical treatment of often life-threatening, life-altering injuries and the complex social needs that often accompany that trauma. I could never do her role justice right now, but I will say that I was at a trauma board round, which is where we discuss the patients, and I was blown away by her knowledge of not just the patient's injury burden and severity, but their social situation, their trajectory of their rehabilitation, the very practical, pragmatic issues that actually were going to determine whether or not they'd be able to get home and what kind of life they'd live when they got home. So thank you. Samir says I bullied him. Yeah, it's probably true. Is a London team manager for St Giles, which is a charity that we're going to hear more about, but in their own words, they work to give a past into a future. Samir is a dedicated youth practitioner who specialises in gangs, youth engagement, peer group violence, county lines, and the risk factors associated. I believe that his premise is that by nurturing people that are marginalised or forgotten or have been impacted by things like this, you can change not just their trajectory, but the trajectory of all of the people around them. And I know that he works to be the change that he wants to see. Again, he's going to tell us more about St Giles, but my own anecdote, I was looking after a patient who had had a knife-related injury. I was about to send him off to sleep. I moved his pillow, and underneath the pillow, there was a St Giles contact card. And I took it out, and he grabbed it from me, and he said, I need that, because I'm going to turn my life around. And it was that experience that made me bully you to come. I'm sorry. But I'm sorry, not sorry.
You should see the emails.
But it worked, and God loves a trier, so thank you for coming. And last but not least, Professor Martin Griffiths. I could never list all of your accolades. Colleague and hopefully friend, maybe not after today, but a trauma and vascular surgeon. He's the lead for trauma surgery at the Royal London. He's the professor of trauma surgery with the Blizzard Institute, and he's the clinical director for violence reduction in the UK. Correct me if I'm wrong, but I feel he's led the country's work on understanding and addressing the social and personal factors that precede violent injury. He doesn't just provide life-saving treatment, which I have seen, to the patients affected, but he works to create coordinated care, to change their life's path. And he's also working to shift the focus towards prevention of violent injury in the first place. He's the chair of the board of trustees of SHIFT, which is a movement that works to break the destructive cycle that young people can find themselves in. And it does this by providing formative and caring relationships. And if you get a chance, I would advocate that you read more into it. So before I finally let you talk, I did go on to watch the documentary that sparked this panel. And I'd like to quote a patient that was helped by services like ours. He said, "I value life a lot more now. There is some beauty in the world for me that wasn't there before." So on that note, no pressure. But thank you very much for coming. And panel, please tell us about the work you do.
Is this thing on? Can you hear me?
Bring it closer.
Bring it closer? Hello? Hello? Oh, there we go. There we go. Right, fine. My name's Martin Griffiths. I'm a consultant trauma surgeon. I've got a lot of hats. I do apologise. I want to take you through a story. And it said about hope today. This is a story of expectation and delivery rather than hope. I want to show you what happens when curiosity meets passion, meets leverage, meets tenacity, and what can change. I'm going to do it through a conversation in the lens of looking at interpersonal injury in a major trauma setting and seeing what happens when you change your focus from injury to people's injuries to injured people. You change your focus from the problem to the person with a problem, and how you build you build consistency, communities of practice, movements, using data, information, passion to build beyond a simple problem. So, context. We're all major trauma practitioners, clinicians, non-clinicians, who work at the Royal London, one of the major trauma centres in the country, 20 in the country. So we look after lots and lots of people who've been shot, stabbed, run over. We're unfortunate in that we're the busiest trauma centre in the country, and we look after about 3,500 major trauma activations per year. Sorry about the numbers. What's challenging about us? A lot of penetrating trauma, knives and guns, lots and lots of young people being stabbed and shot in our services. And these are often 18-year-olds, average age of admission. Most of them walk into 16 years old. These are kids who come from difficult backgrounds, difficult circumstances, and are treated traditionally like dirt because being stabbed is your fault and your problem. Let's go back about 10, 15 years when I was working as a consultant there. We've been established as a major trauma centre for a very, very long time, providing fantastic clinical care, but not giving a toss about the individuals concerned. They're just injuries in beds. Did our operations, sent them home, and back they came. 1 in 3 of our young people came back within 2 years of their injury. Of all the kids we saw who'd been admitted to our service, more of them have been stabbed 1 or 2 times prior to the big injury. And they went home to difficult circumstances with literally no support. And it's very hard as a clinician who's born and bred in London, seeing people who look and sound like you being injured for no good reason in a first world country and coming back despite our best intentions. And that made me quite mad, quite angry, pretty pissed off. We couldn't do that. Even with this fantastic stuff, we couldn't make things better. So I started to think, and I'm not the only person having the same ideas, as you can tell by the panel, my wonderful colleagues. And we had to reframe our anger, reframe our practice, and use that as a means to leverage change within bigger systems. So what we're going to talk about for the next hour or so is about how we started to do the work within the hospital, and how this piece of work has informed us how to change culture, activity, and outcome, how we've engaged community, how we've engaged social care, how we've engaged third sector charities, how we've engaged the NHS to do things differently, and how that's led to system change in London. And that's why London is incredibly safe compared to how it was 10 years ago. But at the end. Is that okay? So, back in the day, 13 years ago, we were looking after, you got stabbed, operated and you, off you went, okay? No support, no social care, no talk to your family, no inquire about what was going on. It's under arrest, not arrest, bad person, naughty. Great clinical care, great outcomes, poor experience. We didn't care about the individual, we didn't care about the circumstances, we didn't care about the context. And that had to change. Had to offer a more holistic support, a better understanding, find out why it happened, be more trauma-informed, more humble, and do something different. Now, in the clinical environment, clinical care is paramount, or so you would think. But supporting the entire individual and the family and the community, I'm talking about injury rather than crime, thank you, okay? Talk about the person rather than the problem, and supporting that individual in more than just physical ways, emotional, psychological, social ways, changes outcome, changes culture, changes delivery, and changes the experience for all concerned. So what I'd like to do first, introduce my colleague Katie, who will discuss our after trauma service, which provides a holistic care that enables individuals to actually grasp how to move through this complex, muddied system of healthcare. And after that, we'll talk to Samir, who talks about the much more important piece about so what, how, and why do you get there, the trauma-informed piece. And then I'll wrap up by talking about how we utilize this fantastic movement and practice to operationalize culture change within the NHS and beyond. Would that be okay? So, over to you, Katie.
Good morning, everyone. Thank you for having us here. This is going to be a sort of generic background about the team that I work in, but I think you'll learn from the sort of work we do how we then mold our services to the individual. So it's not just a sort of blanket service. I think it's been attested to, each patient is an individual and we have to work with them to try and get the best outcome. So we're called the After Trauma Team, and we are 6 ladies, and we are a combination of major trauma nurse coordinators and major trauma rehabilitation coordinators, so with nurses and physiotherapists. We also have a pediatric major trauma coordinator, and we have a welfare officer called Deborah. She used to work for the Department of Works and Pensions, so she is vital when it comes to helping provide our patients with support in terms of benefits, etc. So the team was formed in 2017 off the back of basically national guidelines as to what should be available for patients. We should be available 7 days a week. The patient and the family should be provided with written information specific to the major trauma centre, and that's when we go in and do our bit about the centre, who we are, what we do. It should be able to provide structure and a single point of contact as a patient moves through the pathway. And I think, given a lot of the patients that we have, they are seen by multiple doctors, multiple teams, multiple surgeries, sometimes multiple specialties. So we really like to be that central point of contact for them so that they can come to us and say, I don't understand, what am I doing next, what's happening? And we can try and let them know. And we should also be able to provide education and training for healthcare professionals and patients. And so that's being able to teach our colleagues what it is that we do and how they can help and support as well. This is just a slide that I'm not going to spend too much time on, but this just gives you an outline of London. The squares are the 4 different major trauma centres, and the correlating circles to the square are the areas that we cover. So the role of the After Trauma Team, we are a key worker. So we support families, patients, and the wider multidisciplinary team to ensure timely, safe, and appropriate care in order to maximise their recovery and onward journey. So like I said earlier, we are a central point of contact for the patients and their families. We're sometimes also a central point of contact for the greater MDT so that they can also come to us and ask where we are with a patient's journey. So the role of the After Trauma Team, we undertake trauma education across the trust and wider trauma network systems. We represent at national specialist interest groups, work collaboratively with research teams as well, also locally and nationally. We establish patient involvement groups to try and get an understanding of their feedback and their experiences. We liaise with external partners, so rehabilitation units, trauma-related charities, legal panels, and we support with welfare issues, with, for example, applying for benefits. But what does that really look like on a day-to-day? So we start by identifying the patients who would benefit from the after-trauma team support. We support the patients and their families, not just in the hospital, but at home. And yearly, this totals to somewhere around 3,200 patients. Ensuring plans are in place for injuries, coordinating involvement from the different specialities. A very important one is that we are very involved with the safeguarding of adults and children. And I think you'd appreciate that in the context of what we're discussing today, there is a lot of safeguarding that happens. And with the next one, a lot of safety planning. We liaise with other hospitals in the trauma network and across the UK and at times across the world. And this especially is in relation to repatriating patients back to their local area. We're involved in rehab and discharge planning, supporting the ward and different specialities when needed. And importantly, liaising with the police and the community services. But what does that really look like? So this is just an example, and I apologize that it's not purely related to what we're talking about today. It is a bit of an old slide. But we had a 27-year-old who jumped from the fourth floor, multiple polytraumatic injuries, was in hospital for 12 weeks, including a 6-week stint at a inpatient rehabilitation that we have. So for one of my colleagues, they had 3 contacts with this patient whilst they were in the intensive care, the patient and their family. They had 10 contacts with the patient whilst they were on the ward. They had 5 while they were in the rehabilitation. And then since discharge, there were 17 phone calls and follow-up emails. I genuinely don't think that captures all the phone calls, all the conversations with the family, all the quick chats as you're walking past. But in brief, this person needed to have liaison, we needed to liaise with the police, with the family. There were behavioural contracts that needed to be put in place because of how they and the families were behaving, complex discharge planning, multiple family meetings, and as I said, ongoing as well since discharge, rehabilitation planning, and I think very importantly, advocacy. We have to advocate for our patients and what is best for them, especially in the context of an incredibly busy hospital where we like to get people discharged so that we could get people into beds that are very much needed. But it's definitely our job to make sure that people are going to go home, be safe, and be able to try and put to use some of the life-saving work that we've done and not actually just throw them back into a society where they could be injured again. Future plans, we're going to try and host a National Trauma Coordinator Symposium. We want to, importantly, try to establish an outpatient telephone clinic purely for our team so that we can have greater upkeep with our outpatient load. Trying to embed national competencies across the patient pathways and instigating a patient involvement group. That's just a little bit about. So I think, again, in the context of what's being discussed today, I think working in collaboration with our medical colleagues and the incredible charities like St Giles, but also with the police, with social services, with the safeguarding teams, to ensure that we are advocating for our patients and what their needs really are. Thank you very much.
Everyone hear me all right? Yeah, that's good. All right. St. Giles. Has anyone heard of St. Giles before? Yeah, just one. Just Maria on her own. All right, cool. I think what I've identified in this specific sector and in the context of today is it's always someone else's problem or it's their fault. I think those 2 avenues, if you do adopt those attitudes, I think if you continue to, trust me when I say this, the issue will find you at your front door. And as Maria and me were discussing before we started, she eloquently put, it's our community. It's our community. Now, hope sometimes starts with an idea, but action is equally as important. So for those that don't know who St Giles are, I am not going to give you a long history lesson, but we were established in 1963 in Camberwell, Southeast London. And it has gone on to launch, in my humble opinion, some groundbreaking projects. But I'm not here to talk about all of those projects: homelessness, housing support, gang exit. I'm here to talk about the hospital-based youth work that we provide, why we were created, and the kind of work that we carry out. So, oh yeah, just so you know, whenever you have me in a room and Mr. Griffiths, in good tradition, I have to embarrass him at some point, yeah? And I will keep that, yeah? So you're free to leave now. Again, Kate's covered this and the major trauma. For those that don't know, because I don't know where everyone's come from, but Royal London Hospital is one of 4 major traumas in London. It is the busiest in London and one of the busiest in Europe. We see between 700 and 800 shootings and stabbings a year. So on average, St. Giles will see around 220, but we'll discuss a little bit of data later. You will see Kate referring to 3,200 because they respond to all trauma calls, but we have a criterion which we'll see shortly. So who are we? We're a youth violence reduction service. You will hear the terms serious youth violence. Look, we've become a very politically correct world. I'm very forgiving of language, but I don't really champion the terms serious youth violence for 3 major reasons. One, serious youth violence sounds like it's the children's problem. You go away and you fix it. Young people have also reported as high as the mayor's office that they feel demonized by the term serious. And I always throw the third one in. Isn't all violence serious? So where are you? Look, if you want to use that term, guys, I'm not going to put you in a headlock. But for me personally, we're a youth violence reduction service. Again, I'm a little bit biased. I'm sure you're doing amazing work in all your respective fields, but I'm going to say it how it is. I think one of the best collaborations you'll ever find in the NHS is when St. Giles met the after trauma team, because that collaboration there has shaped what care looks like. They take care of the surgical side, we take care of the pastoral side. So that's just a winning team right there. So we're a youth violence reduction part of that trauma program that you see in Royal London Hospital. And you gave them the exact location, like they want to look for us on 12D, but hey ho. Our criteria is all 11 to 25-year-olds. Those ages are not there for fun. 11 is the youngest we have had for these injuries and background stories. So when Mr. Griffiths was talking about 18, thankfully, I've never had in my 5 years an 11-year-old. My predecessor, Roisin, who's currently our manager, has. The youngest I have had in 5 years is a 12-year-old stabbed 15 times. So that's the youngest we've had. So those ages are not there for far. 25 years old, I say with a caveat now. They say the adult's brain reaches its full maturity, but apparently the male's brain continues to develop up until the age of 30, and my mum agrees with that sentiment. So apparently. I'd say older. Older, okay. So those are the reasons why those age groups are there. And again, we're a wraparound service. What does that look like? We're exploring the next couple of slides. So just pretty much what it says on the tin. I did say, I do like to embarrass Mr. Griffiths. I think that fault was all right. He can pull that one off. But why are we where we are? In 2015, in Mr. Griffiths' own words, he said he was sick and tired of patching up young people only to come back 2 or 3 weeks later. The readmission rates in 2015 were 35%. We hear data like 45%, but that's across Barts Health's other respective sites, but 35%. So look, I get it. He could have easily cashed his clinical check, went home and put a box set on. But he wanted more, and he wanted to reduce this. So what he done was essentially his brainchild. He met Evan Jones. Evan Jones at an event suggested a specific St. Giles model. Founding caseworkers were Roisin and Antonia. And there's only been 2 tenures in 11 years, which is rare. So Roisin's still currently our operational manager, and I've been in Royal London for the last 5+ years. When we went live, when St. Giles went live, the readmission rates in its first 12 months reduced to 1% from 35%. So we're doing something right, yeah? Now, we never collated that data. Your own Bart cell violence reduction lead, so I didn't hide away, collated our data, and raised our jazz hands. We're doing amazing. We didn't do that. Your own Bart cell violence reduction lead's done that. So something was working, but I understand data is very manipulative, and on average, over our 11 years of data, you need to give a patient around 1 year, 10 months to be readmitted. So I only gave you 12 months worth of data there. It looked like we're shining. I'll give you the rest. So during Roisin's 5-year tenure, 7% was the average throughout. What's my point? We, in the last 5 years, kept it at 3.1%. So I'm sure everyone would agree that's better than the previous 35% in 2015. My point is that we have kept a high-performing team for over a decade. And that takes a lot to do. Please don't let that go over your head. Like, there are people who will come in and think the gig's very easy. And as I've said, we're not youth workers. We're way more than that. We're practitioners. We have about 11 hats. We're housing officers at one point, layers of therapeutic support at one point, advocates at one point. The list goes on. So I don't think St. Giles can sit up here and take all of the kudos. I think it is a number of factors that have reduced that level. The team up with After Trauma team and how they advocate and support our young people, ourselves. We have dedicated psychologists now. At one point, we had the police trauma support team who improved my safety plans by 3 months. I mean, they sped them up by 3 months. So it is that kind of African proverb. It takes a village to raise a child. And all of those units moving and pulling in the same space on one program has kept that reduction low. It's not about St. Giles. I just think we're an important cog within that system. That's all I'm saying. And again, just a cheeky little photo there. So that's kind of what we do. We provide emotional support, but again, we don't specialize in those fields. We support a lot of young people accessing those areas. You should see the challenges and barriers to accessing therapeutic support and their opinions around it and not wanting to. And culturally, no, that means I'm weak if I access those spaces. We try to break down all those barriers. Again, preventing a victim becoming a perpetrator. 1 in 3 perpetrators at one point were a victim. It is very important in the hospital space where they are thinking about retribution and revenge and Snapchatting about it, that we kick in to understand how to promote the systems. A hard gig that will come out later. We got a secret weapon, which I think that 35 to 1% was major. And I felt privileged having it. I couldn't believe it. So when this was set up by Mr. G, he also empowered us. And one of the things is, and just so you know, guys, in Royal London Hospital, I have enemies. I have oppositions, as they say in the hood. Do you know who they are? Bed management. Hate us. Because if any of our clinical staff tell our young people who have been stabbed, shot, or seriously assaulted after being medically fit for discharge and say, now you can go home, St. Giles say, we haven't identified safe and suitable accommodation yet, which is very important, they don't go nowhere. Hence why bed management hate us. But I would say to bed management, if we get it right the first time, we'll probably save the NHS a lot more money in the long run. If we are preventing victims becoming perpetrator that has in the past resulted in murder, probably saved you £3 million on a murder trial, it is important we get it right, because if you patch them up and send them back to home in a space of 32 London boroughs, rivals are across the road or a stone throw, survival instincts kick in, they're probably going to fill their bed with another victim or return. So that's one of our secret weapons, and the bane of our work is identifying safe and suitable accommodation, but somehow we pull it off. Again, Kate earlier talked about the coordination of safety planning. I won't bore you with the details there. Quite a lot of energy goes in that, which again, advocacy is needed. Sometimes the voice of the young person is not heard, it's drowned out. It is about bringing it to the table. An assessment without a young person's voice is just a professional's opinion. So it's very important that we are advocating correctly. Again, working with social and family networks, there's no point us working with a young person and mum needs help and dad needs help. Because working in silo doesn't produce the results. Sometimes it's just a repeat. So we do extend our support to families and their networks. And we work with many young people who are in care. No mum, no dad. And again, as Kate earlier said, it's timely and tailored support that we work. What works for Jason might not work for Jane. And that's very important. Again, don't know how much you do know about St. Giles, but I always do this. 40% of the organization come from a lived experience background. They kept alluding to the documentary, and I had some lived experience. Personally, I always do that because I believe everyone in this room has lived experience. I just got caught. Yeah? So it is important to understand that it doesn't mean you're ex-bad boy or ex-substance misuse or gang member. Sometimes lived experience comes in different ways, and everyone's got their superpower, in my humble opinion. So this is just us in motion. Once someone is stabbed or shot, depending on the levels of injury, they may go critical care. We're situated in the after trauma. Again, that is a reachable moment. We go on to introductions. I've gone bed space. I've been there 5 minutes. I've been there for 3 hours. We never know what we get bedside. We then offer our support. We coordinate again earlier on, like I said, a lot of support. Rapport building, I think the longest I've ever had someone in Royal London was 6.5 months. So you could imagine how much Connect 4 we played, but we can have someone out the door within 48 hours, so it does depend. Again, we assess every patient that comes in here, and according to some of the Bart's health leads, St Giles assessments are A1. When we assess them as being high risk, they were high risk. When we assess them as being medium, they were medium. When we assess them being low, they were low. I've seen the charter. We're not telepathic. What are we doing? There's no magic ones. We'll unpack that shortly. And again, tailored support. In our safety plans, in our support plans, it has to be meaningful. The day we become a tick box exercise, I will leave. If a young person is talking about being a doctor, why are you pushing him down the construction road? So we believe in meaningful and tailored support for all young people and young adults we work with. And then we go on to advocate and allocate. I won't brush over advocacy. I really won't. I mean, there's professionals in this space that get it devastatingly wrong. Devastatingly wrong. I remember having a 17-year-old stabbed multiple times from Woburn Forest. We got to the solution stage, and the social worker said, can we just send him back to Pakistan? British citizen, if that means anything to anyone. And you're like, how have you got to that? You helped me to understand after a traumatic event that that's going to be a solution. I remember another incident, won't name and shame the London Borough, got to solution stage, and the professional said, can we just stick a monitor on him and know where he is all the time? And you're like, is that all you got? Some people's intervention is just stop using Snapchat. And I'm glad I'm in these rooms advocating for young people because we get it. We really do get it. Again, pretty obvious, engaging at a crucial stage. Hands up, you think you can do what we do? It's not a trick question. Maria, confident? It's not a trick question. Catherine? I hope you lot say yeah, because then you're part of our workforce. Are you confident?
I'm not confident in anything.
Fair enough. Well, I unpack it a little bit. I do love it when clinical staff say they are confident. Kate can handle her own. Probably the East London in her somewhere along the line. But relatability, guys, whether you like it or not, and this is just a snippet because I know to keep in good timing, about what we are bringing to the table, why Mr. Griffiths wanted a lived experience kind of led project and bought into the ethos of that. Relatability, whether you guys like it or not, it is a segue to engagement. You know, I turn up in no scrubs or Crocs, and there are signifiers that young people will see that you don't see. I'd say about 50% of the time that I've seen from my observations, I will walk in and I see the eyes of a young person, young adult, do exactly this. And Maria, I'm going to use you as an example. Please watch my eyes. I walk in ready to pitch service, and this is exactly what they do, whether they're bleeding or not. What happened there? They don't see where my eyes dropped. What are they looking at? Shout out. Kicks. Footwear. What the heck is my footwear? Guys, don't get shoe conscious now. But they are looking at footwear. I'm being judged before I've even begun to smoke. Lanyards as well. We're judged by lanyards. Like they see lanyards. Why? See you as an authoritarian. It's a barrier to engagement. I have to break down all these barriers before an even offer of support, even before they even accept. So just so you know, guys, I'm having a very good Jordan day today. If you can't see under the table, Jordan 4 Rare Air means absolutely nothing to you, but maybe to the young people. They see these little signifiers. Just so you know, I'm not dressing up to fit in. These were created in 1998. Young people have taken my trainers and just put a different color scheme on. So I'm clearly within my era. Do not be somebody you're not. They will see right through you. So you come in, you're judged by your lanyard, yeah? And the judgments with that is mind-boggling. Footwear. So you have all these signifiers and they kind of validate you. So then they're like, okay, I'll listen to what you got to say. And then the pitch comes along and they hold on to every piece of language that you say. Why? They may have been failed 10 times before from professionals that were wearing that lanyard. They may have been stopped and searched for £10 worth of cannabis, had a disgusting experience. Police officers wearing one of those lanyards, you're the same. They may not like their teacher because they got bad breath and he or she was wearing a lanyard. It is the same for us in the hospital space. So there's so much barriers you need to unpick before you get to, hi, we're St Giles, here to support you, potentially make life better. So relatability is sometimes what they see. Language. Now, guys, I've accepted, I'm getting old. And photographer, wherever you are, right side's my good side. Too much gray over here, right? I've accepted it's almost over. But my cheat code will always be language. Sometimes young people disclose to you what happened only in slang. How do you unpick that? I remember a young person who was actually, sorry for the graphics, stabbed in the neck. And he told me what happened. And he said, yeah, I was ticking a score shot aloud. Would you like to break that down, Catherine? I was ticking a score shot aloud. What do you think that is?
Honestly, no.
So maybe some people in the crowd know that, but I heard 4 key words there because I'm tuned into that frequency. Ticking, score, shot, loud. Ticking is to give in advance. Score is £20. Shot is a sale. Loud is cannabis. He said I was given £20 worth of cannabis in advance. The boyfriend of the girl came around and actually stabbed him in the neck. Right? Now, guys, my point is, what if I said to him, I don't understand King's English, please? Makes them uncomfortable on a bay with 3 other beds. That's their comfort space. In fact, if I do say break it down, I'm wired. I'm a police officer, right? But there's more in those 4 words. You're telling me where you are on the hierarchy list. £20, okay, that's a peb. All right, cool. Are you being exploited? We know the incident. Is there issues going on around there? Is it poverty that you're facing? Do you need a job? And these are the uninformed decisions that they make. So there's so much in 4 keywords. So language is very important. And again, I will be I have changed it. Oh, I've updated it, Kate. Cultural humility. It used to be cultural awareness. And I was like, I can't use that term because as diverse as London is, I'm not aware of all of the Jamaican heritage. I'm not aware of all of the Bangladeshi. Awareness was wrong for me. So I changed it to humility. And I think when we are engaging with a diverse range of service users, we should be adopting cultural humility. This is why we refer to tailored. And I don't know everything, but little things go very far. Again, empathy and understanding, pretty obvious. And one of our USPs is ongoing support. Once they've left your sterile environment, the business end is in the community where it all takes place. Unsafe, once again, predominantly, I've changed it for the other hospital that I work in, but for Royal London, predominantly when you do I need to clarify as well. There are people who are profiled, wrong place, wrong time. That patient definitely exists. But when we do unpack the story, sometimes this is what we find is predominantly debt, peer pressure, mistaken identity, beef, honey trap, popularity, clout, rob, social media, conflict, relationship, drug territories, postcode wars. I mean, 32 London boroughs in London. We're situated in Tower Hamlets. You neighbor Hackney. How many gangs are in Hackney? Mr. Griffiths, do you know? Known active gangs. Oh, good guess. 20. 15 currently active, right? I always say to people, think of a train station, it's a gang, just predominantly. Now, we're returning young people to that. London Fields, well-known gang. Holly Street, well-known gang. One road separates them. So if anyone's turning up for specific injuries, you're almost returning them back to a place of risk. Do you have that knowledge? I mean, it's only next door to your hospital. So again, it's not just putting a support plan in place, it's a competent support plan. I'm nowhere short on time. I don't know why, I throw in the Maslow theory wherever I go, because they wanted a little bit of, I heard earlier on, you see the patient. Well, you guys got vision as well. You lot see the patient as well. We might just see it through a different lens. So you guys know what Maslow hierarchy needs is. And when I was in the hospital space, we deliver training twice a month for clinical staff on the mandatory level 3 safeguarding training. And I remember finishing training once in Royal London. And one of the nurses said, I can't believe I've been living such a sheltered life. Such a sheltered life. And I'm like, where do you live? She said, Newham. If you don't laugh, you'll cry. Londoners are going to have to laugh. Like, sheltered in Newham. Like, okay, but why should I assume that she would know there's a north and south divide amongst young people? Why should I assume that she would know Stratford's red, Forest Gate's blue, Beckton's purple, Plaistows green? Because her head is in books talking about ECMO and laparotomies. I do know what ECMO means, by the way. Extracorporeal membrane oxygenation. Come on, yeah? Not just slang here, yeah? And their heads in those specific books. So I realized I would have to connect clinical staff to understand what they're actually engaging with. And then I went further, and then I thought, okay, cool. There's some misconceptions about our young people, and there's judgment, and there's biases, not unconscious, sometimes conscious. Because they're black and from Tottenham and being stabbed, they must be a gang member. I was like, I'm gonna unpack this differently, because I face kind of like mistreatment myself. So I'm like, if you've got the minerals to say that to me, then what are you saying about our patients in the bed? So I put something together, and just before I end, before the last slide, I thought I'd use them as a free, because you'll understand it. Do not worry, I won't be going through all of it. But if you just look at sleep, for example, some of our young people turn up and have their first 8 hours sleep in 12 months enroll on the hospital, turning up sleep deprived. You look at clothing. Does anyone in here know how much a night tracksuit costs? Shout out a figure. 200. Oh, they're locked in, Catherine. I didn't know that. Yeah, I got schooled on the front line because I was stuck in the 90s. So we had a young individual in a coma for 6 weeks, fortunately came out, absolute success story. And I said to the professional network, because we're just a charity, give us an award. I want to lift his spirits. And they finally agreed. Big up Islam Council. He awarded us £100. So I thought, right, that's a nice tracksuit for himself, some socks and boxes. Flew down to Lewisham, to the place. They no longer live there, so I can name the area, Barking and Dagenham. And it's one of the highlights of my work is lifting a young person's spirit, purchasing staff, having a good time, humanizing them. Had £100. And I could feel him edging back. And he was building up the confidence to say these exact words. No disrespect, Samir, but £100 ain't gonna do nothing. And in my head, I'm like, you ungrateful git. I just ignored him. I said, no, we're good. We've got a tracksuit and some socks and boxes. Romford Market is a place I assessed as being safe for us to visit, and we approached the complex. And I went into JD Sports. And I thought, nice night tracksuit, that will do it. I picked up the night tracksuit bottoms. $89.99. I said, this tracksuit top better be £11. My heart dropped. I put that down. I picked up the matching jacket, $79.99, £160, which young people would do anything to get just to fit in on the block, even if it means grabbing your iPhone on the way home. Now, someone in my lens shouted out, tell them about Vinted. I love Vinted, but not every young person knows about Vinted. So I quickly understood, even if you look at clothing and sleep, you start to understand what young people are actually going through. Safety needs. Does anyone know the most likely time for a child to be stabbed in London? According to a government report, does anyone know? Maria, do you know? Most likely time for a child to be stabbed. I think I heard it. After school. Well done. Well done. After school. They actually give you the exact times. 3:15, 5:30. Now, I couldn't wait to finish school and kick my brother up the arse and get home. Now, as a child in 2026, I need to worry about being stabbed. Mad. And we just look at the safety needs. And when we do put out these plans for young people to come forward, what are they labeled? Snitches, grasses. So we're not meeting the essentials. We're not meeting the safety needs. And love and belonging and self-esteem, I could go on for another hour, and I'm not. But I will ask you to ask yourself, where do they get it from? And where should they get it from? Because sometimes young people will turn up dead, find it in toxic places, and that's something that we can help to bridge, but we can't always provide. It's about them adopting healthier spaces for love and belonging and self-esteem. And I ask you to go away and ask, where do they really get it from? Yeah. Finally, okay, that was just some data. I don't really need to shoot that off. But that's kind of me. Yeah, I left you at 10 minutes. But yeah, thank you for listening. So all I would say is in regards to our specific work, I think we complement the clinical work that does take place on 12D. I don't think we're the be-all, end-all. I think it is about the right individual in the work that they do. I'm very passionate about making a difference. And again, it's always about the people that come behind us that can continue this amazing hospital-based youth work. So I appreciate you guys for listening. Hand over to Mr. Griffiths.
Thanks, Amir. Oh, sorry. Thanks, Amir. Got me? Right, okay. That was great, wasn't it? Nice little story, yeah? In goes a bit of this, in goes a bit of that, and everything's great, isn't it? What a load of bollocks. Right, so that's saying language. So we talk about these niche solutions, these nice little problems, and off we go and read the paper, yes? Problem solved, box ticked. No. Why did it happen? Why is it that your skin tone makes you a risk in this country? Why is it that you being poor makes you a risk in this country? Why is it we have to build these solutions in this institution? How did we get here? How did our organizations become so toxic that they are institutionally biased and create situations where kids end up in these places because of the system's design, not by accident? Now, the Royal London was a test bed for my anger in lots of ways. And we built this program for a number of reasons. Yes, I could see the problem, but I didn't have the skills to manage it. I needed the support of diverse leaders, diverse organizations, and game changers, not just doing the same thing badly. So we reached out to third sector as a charity, and we brought in lived experience people who are super bright, super talented, haven't got degrees, at least not yet, but are incredibly emotionally intelligent, work relationally. Yes, and it transformed our activity, gave us the confidence to take another risk with after trauma team, with bringing on psychologists onto our shop floor. Psychologists that talk to young boys about their emotional well-being. How's that going to work? It's not going to work unless that conversation is culturally competent and brokered by a navigator, like for St Giles, who will contextualize that support and make it make sense. Yes? We put police on the ward. We put police on a ward full of young people. Can you imagine? I want to ask you something. What was that conversation like when I said to you I'd bring the police into the ward?
Hell no.
Not uniform police, but a dedicated set of police officers who are going to work with the young people, providing the support and needs. I got some pushback from bringing St Giles on the shop floor because they were all criminals who were going to actually groom the children and sell them drugs. And I got pushback from my social care team colleagues about bringing police because they're going to all be criminalised everybody. However, to see the way, when we co-located all those teams on the ward, we changed the nature of the communication. We started working relationally, not just with the individuals we were supporting, but as teams. And there was cultural healing, cultural alignment. Everybody wanted to do the right thing together. So, St Giles, after trauma, policing, psychology, cultural change. We talk about patients rather than injuries. We have a flatter hierarchy because we respect everybody. And the young people see a doctor, a nurse, a therapist, a St Giles worker, all being treated the same respectfully. And it changes your impression of what good looks like. We can all work relationally. We all support the individual. We all have our areas of expertise. We all respect our expertise, and we all get the job done. And that person goes home happier, safer, with a robust 3% now? 3% readmission rates for 10, 11 years, rock solid. You can carry something hot for a while. You have to put it down. You can be passionate for a while, can't you? Till you get tired, beaten down by the system, you lose energy, and you hand it over, you give up. But for 10 years requires systematization, requires more than passion, requires data, requires evidence, requires commitment, requires cultural change. And that's what this is all about. So great, we've built this wonderful system in this tiny little box in East London. So what? There are 12.5 million Londoners, and we're providing care for 3,500. So let's export this piece of work. We've taken this beyond hospitals. We do community work. We built programs around that, and we took this piece of work, the NHS London, and I got a job doing that sort of work, and we built a advanced reduction program which worked in tandem with the advanced reduction unit in London, the big culturally unintelligent box as it was, 2019, providing work trying to reduce crime in London, not advanced reduction, crime reduction unit in London, yes, sponsored by the Mayor and central government. There are 20 in the country. Initially, gifting money, acting inconstantly, not looking at causes of causes. But as a healthcare organisation in the NHS, we were saying, so we could show them this system worked. Be more culturally competent, be more culturally humane, walk across agencies, be more transparent, be less transactional. And that changed what the VRU did, and we are now NHS in London is now a very powerful advocate for changing policy. And VRU has changed, and we work actually with the Met, with housing. Housing is really important, if you notice. No base, no base. Yes? We work with education, because lots of things happen in school, don't they? A lot of problems start in school. When you label a child as a problem, rather than potential. When a teacher said that I can see that kid's going in a bad direction, I could see him now going that way. What does that say about that child? That child could pick up when they're 6, 7 years old, they know they've been labelled as being a problem. Why? Because they map to a narrative. They're the wrong colour, they're the wrong size, they've got the wrong demographics in terms of poverty, and they fit a pattern. And they're not boisterous, that's white people, they're challenging because they're black. They're chaotic because their parents aren't both working. And these gentle words we use to describe circumstances in a very holistic, nice way end up being labels that guide us down the pathway to exclusion and limiting choices. And there's no doubt that our systems are perverse. And despite our best intentions, we create systems that demonize and marginalize as a matter of course. And we have to break that narrative. So working collaboratively across the piece, we've changed the culture, changed the organisation, changed the intervention. Most of my work in NHS London is about mental health, putting in place community programmes. No knife bins, no bleed control kits, no helicopters, no jumping up and down saying don't do this. It's how can we support you in the community you live in? How can we contextually safeguard you rather than do things to you? How can we work with your community? Our work is about empowerment and engagement and working alongside other agencies who have other skill sets, like the police. It's about having a home that works, about having parents who are going to support you, because building that relationship between parents and children, okay, is the strongest bond, the most resilient bond. It's built on what? Love. It's built on love. The one thing everybody needs. Might deny it, but you need it. It's built on the faith. I love you as you are. I love you for what you can be, but I don't mind what happens because I still love you. And I will forgive you because I love you. And when you fall over, and you've all fallen over, haven't you? And you all got up, haven't you? Was it on your own? What are your best times on your own with other people? Happy days of your life, are they on your own with other people? We all work relationally. Individuals, organisations, and systems. Driven by passion for a while, but powered by data and information. And I'm sorry, numbers do matter. Because they write checks, don't they? Remember checks? And for us to pay for St Giles, we need the data. For us to pay for the earth, the game-changing service that the after trauma provide, that St Giles provide, that psychologists provide, we need data to satisfy people who do not care about these kids. Because until it's your child, you will not care. Until it's somebody you know or care about, you will not care. I know you won't care. You won't care about the war in the Gulf until you pay more money for your petrol in your car, will you? You can turn over, can't you? Until it's how much a litre? And suddenly it's a problem for you. I'm not being mean, I'm being transparent. So put yourself in the place of that child or that parent who's working their arse off, trying to be the best parent they can be, the good enough parent, who's always failing in everybody's eyes. What do? We demonize, we marginalize, we chastise rather than support. We lose perspective rather than gain compassion. And this system isn't some naive nonsense. I've got the data to prove that it works. We can work collectively, we can work transparently, we can work humbly to build systems that work micro and macro in institutions and in community that change experience, access, outcome, policy, strategy. Everything we said to you today has happened. And it's not just the Royal London reducing readmission rates from 35% to 3%. In London right now, as we speak, the lowest rate of homicide ever recorded. Reductions in injuries in every borough of London. Hospital admissions for penetrating trauma have never been lower than they are right now. This stuff works, but it's built on love. Thank you.